IPAC removal. Let me briefly introduce myself. I finished my resident training in President Transconjunctival in Hung-Chang Hospital and completed my fellowship in Johns Hopkins Hospital for ID reconstruction and aesthetic surgery. This is the outline of today my presentation. I will quickly introduce my practice for lower ID deformities and introduce my study about Kaohsiung laser assisted transconjunctival IPAC removal. For lower ID deformity, in my opinion, there are three major problems. The first one is foreign deficiency, which cause knee-joint junction, nasal group, and mid-face depression. The second major problem is sugar herniated fat, which causes IPAC. The third problem is wrinkle, which is from skin laxity. There are many classifications for lower ID deformities. But for me, there are two wording, and it's not easy to practice in my general practice. So I developed my own classification. I will introduce that later. And this is the evolution of lower ID surgery. And the history of lower ID surgery begins about 100 years before. I think it's a process from subtraction. In the beginning, people just remove the skin and IPAC. Then gradually, people think that too much IPAC removal will cause a sclerosed periorbital depression, and which cause patient looks aging and looks tired. So gradually, in recent years, people start to think that fat is variable and it's not good to remove it all. So the concept of fat graft it begins in 2011. So right now, many plastic surgeons do the fat graft during the lower ID therapy process. This is my classification for lower ID deformity. And when patients are young, usually they only have one problem, that is heel trauma. So if the patient has only one problem, they need only one treatment. In my practice, I do fat graft for this patient. So one problem, one treatment is my class one. When patients become older, they may have the IPAC. So they have two problems. They need second treatment, that's transconjunctival IPAC removal. So two problems, two treatments, that's my class two. A patient maybe beyond 40 years old, they have skin laxity, so they have third problem, they need third treatment, that is pinched skin removal. So in my classification, you have one problem, that's class one. You have three problems, that's class two. The fourth classification is specialized. It's usually seen in the Caucasian people. This is because of too much foreign deficiency and skin laxity, which cause a bastion over the knee fat. This is the famous actor Tommy Lee Jones. You can see he has a obvious bastion over his knee fat. That's because of foreign deficiency and skin laxity. So, how to treat this patient? In my practice, my first step is defense and lower ID implementation. I divided a force of unit over the lower ID and detailed report factor amount in each subunit. Usually, each ID needs 2 to 3 cc factor. And I use Smedtrum to do the factor. My second step is transconjunctival IPAC removal. I use either CO2 laser or I use the traditional monopolar electrode surgery. And I weight the amount of IPAC I remove. And usually, each side of the lower ID, the average fat removal is 0.5 to 0.6 cc. So, in my opinion, to regraph the removed IPAC for lower ID is not enough because, as I mentioned before, I grab each ID for 2 to 3 cc. Then I recall only 0.5 cc for each lower ID. The third step is pinch skin removal. I preserve the applicated ocular muscle. And there are more and more literature mentioned that if we injure the applicated ocular muscle, we may destroy or we may make the risk of lower ID traction and extortion. And people with muscle fullness in Chinese is 卧蚕。卧蚕 is for blood. So if you cut the muscle or if you remove the muscle, the pre-muscle fullness might disappear and it might cause problems. Let me show some my cases. This patient is a type 1 patient. She has a big vestibular trough, so I only do fat graft, and then she has a good result and happy in my practice. When patients become older, they have a second problem, IBAC and sugar remaining fat. So I do fat graft and transconjunctival IBAC removal for this patient. This is positive result. When patients have 3 problems, skin laxity, then they need fat graft, transconjunctival IBAC removal, and pinch skin removal. This is type 3 patient. This is another class 3 patient. I do the 3 combined programs for this patient and the brow and skin removal. I did not do the adequate. The adequate is there, just covered by the necessary skin. And we can see the amazing change. And for type 4 patients, this patient usually have the Smedtrum over their mid-face. As I mentioned before, it's because of foreign deficiency and skin laxity. So I cut 10 millimeters skin over here and do OCT fat graft for mid-face and lower eyelid, and this is a post-op result. Then I collect my patients and share my experience and new clarification and publish in the Aesthetic Surgery. It's the official journal of ISA. The second, I will introduce my study. I compare the CO2 laser and the traditional method for IBAC removal. The CO2 laser, as people know, the wavelength 10,000 and 700 nanometers, which is strongly absorbed by water, which means it can induce a certain temperature rise in intracellular water and induce the preparation for tissue. So it has the function of simultaneous cutting and coagulation. The CO2 laser was first used for surgery was in 1984. Then there are many people, many doctors trying to use CO2 laser to do surgery. And because CO2 laser have simultaneous cutting and the coagulation, so some doctors think it can save time and it can reduce post-op bruising. But some doctors think it's not helpful and you have to spend a lot of money to buy a new machine. However, I reviewed this paper. Most of these papers are subjective opinion of the doctors. They do not objectively compare the outcome of the CO2 laser and the traditional method. So I think it's my chance to conduct an objective study to compare these two surgical tools. So I randomly separate my patient in 2 groups. One is use the CO2 laser to remove the IBAC, the other use the traditional removal cover. From 2018 August to 2021 March, I collect 78 patients and randomly divided 2 groups. Then I objectively and quantitatively assess the intraoperative outcome and the post-op outcome. Intraop outcome including the intraop heat, intraop pain, surgery time, and the blood pressure. If you have done the transconjunctival IBAC removal, patient will complain, it's so hot. So patient will complain hot and pain. And for the post-operative outcomes, I check if patient have less hemosis, less conjunctivitis, or less bruising, which is hemosis, and patient certification. For the intraoperative outcomes, the demographic data, fat and local and daily volume, and there are no difference between the 2 groups. The age and the male-female distribution, and there is no difference of these factors. For the surgery time, previous literature say that CO2 laser can reduce the surgical time. But in my hand, I think that it needs longer learning curve because the CO2 laser have a big hand piece, so we need to be happy with the hand piece. So if there is a learning curve, then you need more time to prepare the steroid preparation, and the laser has refraction. Then refraction might cause damage, so we have to set up the laser refraction protection. I think that's because this is the why and the scope, the surgical time, there is no difference. But for the patient's subjective sensation of heat, I will ask patient what heat sensation from 0 to 10, what is your opinion? And I record the number patient tell me. And I found that patient has significant less intra-op heat sensation. People will feel more comfortable during the CO2 laser because they cannot feel the heat during the surgery. Well, for pain, though the average pain score is less in the CO2 laser, but there is no significant difference for pain sensation during the surgery. So the intraoperative outcome, only intraoperative heat have significant difference. For the postoperative outcomes, the chemosis, which usually happens after surgery, which is swelling of bubble conjunctiva, and we found that there is significant difference of chemosis in CO2 laser group. This is because the traditional phobia they have lateral thermal injury, which might cause the lateral injury, the thermal injury to the conjunctiva. You might not notice that, but if you do surgery, quite common. When you use your hand to close the traditional the OP heat, you can feel the heat. And even our hand can feel the heat, so the conjunctiva might be more easy to have the heat injury. So that's why I think chemosis is significant decrease in the CO2 group. Conjunctivitis is inflammation of conjunctiva. And the two groups, the distance of conjunctiva is less in CO2 laser, but no significant difference. And about the chemosis score, the previous literature only record the doctor's subjective. They just think, oh yes, patients have less chemosis, but they did not explain how they record the chemosis. So we make this chemosis score, and we asked 6 experienced surgeons and 1 PIs, our nurse, to doing the evaluation for all 70 patients. So the average chemosis score is less in CO2 laser group, but there is no significant difference. So in my experience, I think CO2 laser did reduce bruising after surgery. So the result, patient's subjective intraoperative heat sensation was significantly higher in the monofocal electro surgery group and less in CO2 laser. The CO2 laser had lower incidence of post-op chemosis. And the final aesthetic outcome, there is no difference between the two groups. Is CO2 laser reduce surgical time? As I mentioned, that CO2 laser need more learning curve, and it has large CO2 laser handpiece. We need to prepare that for steroid preparation, and we have to prepare the refractive energy surgery. The refractive energy might damage to patient and doctor, so we have to protect ourselves and our patients. There is a paper that mentioned that the refraction laser from the polished eye place might make a hole on growth and make flame and fire on the surgical form, and even it can make service divert or irregularly on the endotracheal tube. So the refraction needs to be protected. Conclusion: and patient report that there's intra-op heat by CO2 laser, and it's significant decrease the post-op chemosis. We published this result in the leading paper of the president in control surgery, and it's the cover issue of this October. And I know that time is up, but let me show you a video that I used the first made in Taiwan CO2 laser to do the transconjunctival removal. Usually, there is no breathing during cutting. If you use the blade, if you have done that, you will notice breathing during the transconjunctival approach. Then after I cut the conjunctiva, I will make a traction suture. Then I can start. It has seen coming. This is how you remove the iPad. You can see my box. This is the protection location. Almost no bleeding. Then let me show you the result of this patient. This is pre-op. And this is a type 2 patient. She has a minimal IBAC control. So I do transconjunctival IBAC removal by the MIT CO2 laser. Then I do backward for this patient. This is the POT7, almost no bruising, and have very good recovery. And this is the post-op 2 months. This is the final result. And thank you for your attention.
Smedtrum.